Welcome to Lecture 7 of the Cardiovascular section of the Integrative Systems Physiology course. So today what we're going to start talking about is a bit of an overview of the vascular system, as well as starting to move into Guyton's analyses of the cardiovascular system, which really are focused on the integration of the function of the vasculature with central circulatory function. And to give you maybe just a little bit more detail in terms of where we're going to be headed today, we'll start off with just talking about what actually drives blood flow within the circulation, cover some of the normative values that are in the circulation, as well as the application of the Fick equation to understand some of those values and their interplay a little bit more thoroughly. And then we'll move on to the structure of blood vessels and the implications of those structures for central circulatory function, and then ultimately end up with Guyton's analyses of circulatory function and some examples therein. So when we ask the primary question of, well, what drives blood flow in the circulation, it's relatively straightforward for an answer. It is an overall pressure gradient. And so the pressure gradient, certainly for the systemic circulation, is the difference between the left ventricle, or one pump, and the right atrium, or the entrance to the right-sided pump of the circulation. So essentially, it's that pressure gradient from pump to pump. Now, when we start to evaluate, well, what happens when we start to change driving pressure, we can generally agree that it's usually expressed as a change in right atrial pressure. And right atrial pressure is generally thought of the filling pressure into the sort of backside of that left ventricular pump, or the left-sided pump. And so when we look at normal cardiac values, for example, now if we say, well, it's cardiac output, normally about 5 liters per minute, in a 70 kilogram male, the cardiac output is equal to the product of heart rate and stroke volume. Of course, cardiac output in steady state has to equal venous return. Heart rate, as we've discussed before, between 60 and 80 beats per minute in a normal healthy individual, and stroke volume is roughly 70 mils per beat. So when we start to take some of these normative values and plug them into the Fick equation, or the Fick principle, the Fick principle essentially states that cardiac output is equal to oxygen consumption divided by the arteriovenous oxygen difference. And so oxygen consumption in a 70 kilogram male, which is sort of our frame of reference for a lot of this, is generally around 250 mils of oxygen per minute, or about 250 liters per minute. Cardiac output, again, being roughly 5 liters per minute. And so then when we start to look at the arteriovenous oxygen difference, we can say, well, first off, I think it's important to understand, well, what is that major carry of oxygen in the blood, and how much oxygen we're looking at in terms of the upper end prior to, on the arterial side, prior to it being reduced after going through the circulation and ending up in the venous system. And so, of course, hemoglobin is the predominant carrier of oxygen within the blood, and that carries roughly 19.7 mils of oxygen per deciliter of blood. Plasma actually carries a very small amount of oxygen in relative terms, so it's roughly 0.3 to 0.4 mils of oxygen per deciliter of blood. And so altogether, at sea level, the normal individual will have roughly 20 mils of oxygen per deciliter of blood. So that's units of oxygen per unit volume of blood. And so when we return now to our Fick principle, we can start to plug some numbers into this. We can say, well, if we've got roughly 5 liters per minute cardiac output, roughly 250 mils per minute, or 0.250 liters per minute of oxygen consumption, we can solve for the arteriovenous oxygen difference, which ends up being about 5 milliliters of oxygen per deciliter of blood. So again, that's arterial minus venous, so 20 minus 5, that ends up leaving us with about 15 mils of oxygen per deciliter of blood in the mixed venous blood. And that is important because what that means is that should you start to vigorously exercise or have a substantial stress, that you do have significant buffer and you do have significant reserves in that venous blood, and certainly after the arterial blood has generally gone through the muscular bed, to extract more oxygen as needed. And so that can widen that arteriovenous oxygen difference prior to increasing blood flow, which generally has a slower lag. So now if we start to get more towards our primary question, which is, well, what was that relationship between right atrial pressure and cardiac output? And as it turns out, it is a bit tricky, and it's maybe not as straightforward as we'd like to think it is. And so a lot of it depends upon the context and the design of the experiment. So generally speaking, in Guyton's experiments, the general concept of the preparation has been this, and is that there's an open reservoir here, and so it ends up being an open system that feeds into the to the right atrium, that ends up filling the right atrium, and then it allows blood flow to go through what would be a pulmonary-like circuit, ultimately come back into the left side of the heart, and then be pumped out to the circulation, or this surrogate for circulation, and then come back and then go back through the circuit. Okay, so the important thing here is that there is a reservoir here, and as that reservoir changes, that's going to change, the height of that reservoir changes, that's going to change filling pressure of the right atrium, and then we can understand, at least with an open system, what are the implications of that for changes when right atrial pressure changes. And the important thing here is that when the primary change in a variable is cardiac output, when you increase cardiac output, you decrease right atrial pressure, right? And that's really depicted here. So as cardiac output increases, you can see that central venous pressure progressively decreases. And you can say, well, that makes sense, because in a lot of ways that's just suctioning blood really towards the central circulation. As the heart beats more rapidly or more vigorously, during the subsequent beats, right atrial pressure is going to fall, and that's going to widen the pressure gradient from the systemic circulation and augment venous return. And so again, it's a little bit complicated. Whereas the reciprocal would be is that if you increase right atrial pressure by increasing the height of that reservoir, that will also increase cardiac output. It'll increase cardiac output via a different mechanism, which is essentially through increasing the driving pressure and increasing preload into the right atrium, which subsequently go through the pulmonary circulation and left ventricle and increase cardiac output. Okay. So, of course, this whole interrelationship between right atrial pressure and the net effect on venous return and or cardiac output is complicated by the varying structures throughout the vasculature. And so at this point, what we're going to do is we're going to take a deeper look at some of the structures within the vasculature, how they function in ways that have implications for the central circulation. And then we'll come back to venous return and cardiac filling pressures in more depth. So as we know, when we're looking at vessel size, certainly vessel size, as we go from large arteries to smaller arteries to arterioles to venules, and from arterioles to capillaries to venules, you can see that actually as these vessels branch, we're actually increasing cross-sectional area quite significantly, and the vessels are becoming much smaller, and so this combination ends up minimizing diffusion distance at the site of the capillaries. And so, of course, that's incredibly important, and that can be depicted here just to show you schematically, how dramatic this increase in cross-sectional area is to optimize diffusion distance, also reduce velocity as blood is going through these very large cross-sectional area capillary beds, and that maximizes the time for equilibration and nutrient exchange as well. And so if you look at starting here, of course, on the left side of the heart, going through the systemic capillaries, you have a massive amount of cross-sectional area. Of course, importantly, when you come back to the right side of the heart and then go through the lungs, you have an even larger cross-sectional area in the lungs. And of course, that would make sense because we want to be able to oxygenate that blood adequately as it goes through the lungs and subsequently bring oxygen to the systemic circulation. As stated here, reciprocally, blood velocity drops dramatically in both systemic and pulmonary circulatory beds. Now, that in and of itself doesn't necessarily have that many implications for how the systemic circulation interacts with the central circulation, but the arteries, larger arteries, do. And so when we're looking at changes in vessel size and wall thickness throughout the vascular system, you can see that when we look at the aorta or medium-sized arteries, arterioles, precapillary sphincters, of course, all of these are relatively muscular. They are, of course, exposed to very high pressures. And importantly, as we get to arterioles in particular, they are absolutely critical to being able to control regional blood flow. And so their changes in arteriolar tone are incredibly important for the redistribution of blood flow through changes in resistance. Of course, it would make sense when you look at the relative proportions of smooth muscle versus vessel size. Now, importantly, also when you look at the connective tissue properties of arteries, these have a tremendous amount of elastin in them. And so here, with a vessel being relatively elastic, there can be storage of significant amounts of energy within the vessel wall, which, of course, as we talked about last time with the Wigger's diagram, some of that potential energy is stored so that during the diastolic phase, we still have anterograde blood flow due to the potential energy stored within the vessel wall, which ultimately passively sort of contracts down, or that's imparted to blood flow during the diastolic phase and serves to buffer so that we don't have very large changes of blood flow only during systole. Now, of course, when we look at a true capillary, with true capillaries, they are extremely small, internal radius of 3 microns, wall thickness of 1 micron, and again, being predominantly comprised of endothelial cells. And so these are just extremely thin and are there to maximize diffusion, right, and optimize diffusion and minimize diffusion distance. Now, when we start to come back to the central circulatory system after we go through the capillary beds, you can see here that with venules, veins, and certainly the vena cava, again, now we've got vessels that are predominantly comprised of muscle and collagen. And again, these are very low pressure. If we even look at the elastic fibers as well, now we don't necessarily have that much elastic fiber inside the veins or vena cava as compared to the aorta or other large vessels, other large arteries. But again, this is serving as largely as a conduit back to the heart. And I think when we start to look at the pressure-volume relationships in arteries and veins, hopefully it'll become pretty evident as to why this is actually functionally incredibly important. So, for example, here, when we're looking at the pressure-volume diagram, and we've got transmural pressure on the x-axis, we've got volume on the y-axis, you can see that as certainly with transmural pressure, at very low transmural pressures, we can have extremely large increases in volume in the veins, which, of course, is very important for facilitating the storage of blood flow within the venous circulation, whereas in aorta, you see that we get the increases in transmural pressures, but we don't have quite as large of an increase in volume at any given transmural pressure. Now, we can, of course, flip this and rotate it so that we've got a pressure now on the y-axis, volume on the x-axis. And if we translate this one more time, so now if we have transmural pressure on the y-axis, if we convert that to tension, a radius tension relationship, what you can see now is that arteries actually have a relatively high tension at normal operating pressures and operating volumes. And so you can see here, if we just take a given degree of tension, you can see that the aorta is having a much greater tension as compared to the vena cava at any given radius. And so critically here, again, this is important for the storage of energy within the vessel wall during a diastolic phase, so that way we can have blood continue to flow forward during that diastolic phase that's stored in the vessel wall. And of course, with the vena cava, you can have an extremely large radius with relatively low tension, which is consistent with the function of the venous vessels as being capacitance vessels or storage vessels, storage sites for large volumes of blood to be mobilized later when it's needed in terms of at times of stress. So when we start to take some of these mechanical properties and put sort of variables of interest to them, we can see here that With arteries, they have relatively low compliance at normal operating volumes. Certainly that corresponds to a relatively low distensibility. Sorry, it's kind of sort of covered up here. Vascular distensibility is really just that increase in volume normalized by the original starting volume. So compliance in and of itself does not normalize for your starting volume of the vessel. But of course, the aortic vessels and arteries are less compliant, less distensible. Whereas with veins, we're at a relatively high compliance at normal operating volumes. You can see here that, again, compliance being the increase in volume divided by the increase in pressure, and again, vascular distensibility in the veins being far higher than it is in the arteries. And so then we move on to asking the question, well, what are the implications of these mechanical, structural, and physiological properties in terms of the function of the central circulation? And so one is that the changes in arterial compliance have profound implications for ventricular afterload. So if we look at the effect of aging, for example, on the pressure-volume relationships in the blood vessels, you can see here that, so again, we've got transmural pressure on the x-axis, volume on the y-axis. You can see that with any given increase in volume, which we would say, let's just say there's a stroke volume of 30 mils per beat, for example, you can see that with increasing age, with either your age range versus my age range, you can see that you would have, with a 30 mil per beat stroke volume, change in pressure of roughly 40 millimeters of mercury. Whereas for me, with that same stroke volume, with a less compliant aorta, now I will have a change in blood pressure of 55 millimeters of mercury during that systolic phase, which again has profound implications for clinical manifestations of conditions such as hypertension. So here again, just depicting that age vessels, we're looking at vessels being less compliant and having higher levels of tension. So you can see here this with the radius tension diagram. At any given radius, those blood vessels, those arterial vessels, having far greater increases in tension that's generated and subsequently is transmitted into an increase in systolic pressure and ultimately pathophysiology of isolated systolic hypertension. So when we look at this specifically, again, we've got our pressure-volume relationship here on the left. We've got representative changes in blood pressure on the right. And as we go from 0 to 20, you can see that you have these progressive increases, which are largely normal, right? From 20 to 40, you start to level out here pretty significantly. 40 to 60, for many individuals, certainly diastolic pressures don't necessarily change substantively, but systolic pressures start to creep up a little bit here. And then as you go over 60, then you start to see this more significant drift up, which is consistent with greater stiffening of the central vessels and pumping of a given volume of blood into a more stiff vessel will result in a larger deflection in systolic blood pressure. And again, when you're looking at somebody who is, let's say 20 years old, who might have a systolic blood pressure of 120, for that same degree of cardiac function, should that be maintained, now they'd be having a systolic pressure of greater than 150. So clinically very significant, physiologically very significant. So that's largely on the arterial side. When we look at the venous side and ask the question, well, what happens over there that ends up being significant? These structural differences in veins have quite profound implications for blood storage and blood mobilization. And so when we look at the vena cava, for example, you can see here that with relatively small increases in transmural pressure, we can have relatively dramatic increases in relative volume that's stored in these blood vessels and ends up being able to be mobilized as needed. And you can see that the arterial system, again, it just does not have that same steepness of that curve, and of course operates at a relatively smaller operating range than the venous system. And the veins, they serve as excellent blood reservoirs, and so when we look at where blood sort of resides in a normal circulation at rest, The pulmonary vessels only have about 9%. The heart only has about 7% of the total blood volume. Systemic arteries only have about 13%. The capillaries, they only have about 7%. The systemic veins and venules, they hold about 64% of your total circulating blood volume when you're just hanging out, resting. And so that's a tremendous amount of blood volume that can be mobilized centrally and pushed into the arterial circulation on an as-needed basis, should you have the need to increase preload and subsequently increase cardiac output. And so that the easiest way to mobilize that really is through muscular contraction. So when we take a quick interim summary here, we say, well, when we're looking at pressures in these two systems, arteries, of course, have high pressures, veins have relatively low pressures. With regards to compliance, arteries have low compliance and low distensibility. Veins have high compliance, high distensibility. And importantly, then subsequently, when we're looking at the collapsibility of these vessels, arteries, they're really not very collapsible or not very distensible. And if you do a gross heart dissection, I mean, you'll see that if you just cut a ring of the aorta off and set that on the table, it'll be much less likely to collapse fully versus a vein. If you cut out a ring of the superior or inferior vena cava and set that on the table, that'll fall flat as a sheet of paper instead of forming any sort of circular structure. So again, very collapsible, very compressible in the venous system, thereby facilitating their role as the capacitance vessel and mobilizer of blood flow and blood volume in response to stress. So we'll pause here for a second and just say, well, that's great, right? Hopefully that's all relatively straightforward, somewhat review material to varying degrees. But you're probably asking the question, well, what does that have to do with these right atrial pressure cardiac output relationships and pivotal parts of the function of the central circulation and its interplay with the systemic vasculature? And I would argue that functionally, central hemodynamics, they are really inextricably linked with peripheral vascular dynamics and peripheral vascular mechanics. So, again, when we're looking at this relationship between cardiac output and right atrial filling pressure, again, this is an open chest system, and if you increase filling pressure, which is the height of that reservoir, you'll be increasing cardiac output, and that's shown here relatively straightforwardly. So if you start out with the right atrial pressure, which is normally around 0, you can see that you've got the normal cardiac output right around 5 liters per minute, as we discussed. If you increase right atrial pressure further, you'll end up increasing cardiac output in a relatively linear manner, and ultimately to a point where you'll be unable to increase preload further in a functional way to increase cardiac output. And so then at that state of contractility, or that inotropic state of the heart, that will be the maximum cardiac output that you can achieve under such conditions. Similarly, if you reduce the height of that reservoir, which would be analogous to hemorrhage, for example, or blood loss, there you'll have reductions in right atrial pressure or reductions in central filling pressure, and that will reduce cardiac output. So hopefully that makes sense. Now, with Guyton's curves, now of course they often refer to this as a hyper-effective or hypo-effective heart. So with a hyper-effective heart, for example, that would be delivering exogenous inotropic agents such as norepinephrine to bind to beta-adrenergic receptors and increased calcium-induced calcium release. There you can see that on any given level of right atrial pressure, you can have a very dramatic increase in cardiac output despite the fact that you have the same cardiac filling pressure. And of course, should you increase right atrial pressure as well at the same time, then you can have a much more significant increase in cardiac output, which will ultimately peak at some point out here. Now, reciprocally, if you have a hypoeffective heart, so for example, either heart failure where you have significant scar tissue or significant damage to cardiomyocytes, or administration of something like a beta blocker where that's going to be reducing the contractile state of the heart, reducing calcium-induced calcium release, you can see now that on any given level of right atrial pressure, that now you'll have a substantial reduction in cardiac output, right? And of course, your maximum cardiac output will also be significantly reduced. So hopefully at this point, both of these sets of curves, the hyper-effective, hypo-effective in relation to the normal right atrial pressure and cardiac output relationship are making some sense. Now, if we start to look at varying interventions and the relationship between cardiac output and right atrial pressure and some things that are relatively complicated, you can see, for example, if we look at an intrapleural pressure, about minus 2 millimeters of mercury, so that's a pretty normal intrapleural pressure. You can see that right atrial pressure now these right atrial pressures can be shifted slightly, and so the issue here is that the intrapleural pressure is the space that surrounds the heart, and so the pleura is the space, the pleural space is that which surrounds the lungs. So as you take a breath in, you end up receiving having a more negative intrathoracic pressure, right, and that essentially pulls outward on the lungs and enables the lungs to expand. Of course, similarly, that will pull outwards on the heart, and that will be augmenting it'll be augmenting the pressure gradient, the transmural pressure gradient across the right atrium. And so what you can see is if you just say, well, let's take a look, for example, at we've got a normal intrapleural pressure of about -4. Okay, so if you're here and you've got a normal right atrial pressure, we get cardiac output of about 5 liters per minute. Now, if we have a more negative intrapleural pressure, right, so you start to take a breath in, you pull outwards on the heart, that's going to widen that transmural pressure gradient across the heart. And what that will do is that will make it look like at any given right atrial pressure, you will actually have a wider transmural pressure, and therefore that wider transmural pressure is going to enable cardiac filling more significantly, and that will result in a higher cardiac output at any given absolute right atrial pressure. And again, this sort of comes back to the concept that we were discussing about before with Starling's mechanisms of the heart, where if you're not effectively measuring transmural pressure or wall stress across the ventricle, you're really not getting a full picture of what preload really looks like, and I think that's amplified here. And so similarly, if you go in the opposite direction, where now instead of being at 5 liters per minute cardiac output at a right atrial pressure of roughly 0, when we get a less negative pleural pressure, or even a positive pleural pressure like you would have during expiration. So now you're actively breathing out, and that active breathing out is compressing the lungs, it's also compressing the heart. You can see that what you're going to have to do is you're actually going to have to increase right atrial pressure quite significantly in order to even have a relatively normal cardiac output. And so that increase in right atrial pressure in this context now can only come through increasing the height of that reservoir. Right, so you're going to have some central mobilization of blood towards the central circulation to overcome that compressive force of the intrathoracic pressures on right atrial filling, and ultimately on cardiac preload and cardiac output. Now, when we look at things like cardiac tamponade, where, again, cardiac tamponade is the filling of blood in that pericardial sac, ultimately compressing the heart, it's very similar to what you'd observe here with changes in intrathoracic pressure. When we're looking at normal intrapleural pressure, you can see with very mild tamponade, you'll have a reduction in cardiac output because of that compression of the heart that isn't necessarily being reflected in an absolute intra-atrial pressure, and that can become much more severe as this becomes worse over time. And so here it just has 2 varying degrees of cardiac tamponade, and so if you don't alleviate that over time, of course, then ultimately you'll have central circulatory compromise and reductions in cardiac output. But again, these mechanisms are not so dissimilar, and what you just have to think about is what's going on the pressure around the heart, and then how do I calculate a transmural pressure so I can appropriately estimate the amount of filling that's going to be in the right atrial and what this right atrial pressure is actually representative of. So again, if we take this and just sort of walk through this in sort of step by step, if we're looking at a more negative pleural pressure and that venous pressure is being held relatively constant in the reservoir, that more negative pleural pressure is going to result in a wider right atrial transmural pressure. That more negative right atrial transmural pressure is going to result in a wider pressure gradient for venous return. You're going to have a central blood volume shift, an increase in preload, and at any given absolute right atrial pressure, you're going to have an increase in cardiac output. Okay. Similar to the opposite degree, when you have a more positive intrapleural pressure or a less negative intrapleural pressure, such as you would have during expiration, there it's a compressive force on the heart. So again, venous pressure being held constant, this less negative pleural pressure is going to result in a smaller right atrial transmural pressure. Transiently more positive right atrial pressure, a smaller pressure gradient for venous return, and you're going to have a blood volume shift to the periphery, which is going to reduce preload in the absence of any sort of compensatory mechanism. So at any given absolute right atrial pressure, you're going to have a decrease in cardiac output. Cardiac tamponade, again, venous pressure being held constant inside the reservoir. You're going to have a more positive extracardiac pressure, smaller right atrial pressure, the right atrial transmural pressure. That more positive right atrial pressure is going to result in a smaller pressure gradient for venous return, blood volume shift to the periphery, reduced preload, and at any given absolute right atrial pressure, you have a decrease in cardiac output. So virtually identical to what you see with a more positive intrapleural pressure. So, again, when we're looking at this sort of first set of curves, you just have to sort of stick this in the back of your mind of how you're going to attack this physiologically, is to think, okay, preload is wall stress, and wall stress is this change in transmural pressure times the radius divided by 2 times the wall thickness. And most of these graphs are never showing the change in pressure. They are just showing you intravascular pressure. And so only by displaying that intravascular pressure only, it is really easy to fall into the trap of forgetting about transmural pressure and how that influences filling of the right atrium. So really just sort of keep that in mind and just break this down sequentially, and you should be fine. So if we start to look at other curves here now, you can see we've got a second set of curves. Again, right atrial pressure on the x-axis, cardiac output on the y-axis. Now we're looking at a normal curve in red, and in a combination of rather complicated combination here. So you can look here. We've got a hyper-effective heart with an increase in intrapleural pressure. So you can see here that at any given level of right atrial pressure, you can see that with this hyper-effective heart, it takes quite a bit of effort to actually get to the point where right atrial pressure becomes significant enough to overcome that increase in intrapleural pressure. But then ultimately, you can actually have a higher cardiac output than you would normally because you have a hyper-effective heart. It's just right shifting this curve substantially, so that way you get a right atrial pressure or intraluminal pressure or filling pressure and transmural pressure gradient that's efficient to equal preload here, and then ultimately increase cardiac output higher because of the hyper-effective state of the heart, or higher contractility, the higher state of contractility. Reciprocally, when we're looking at the hypoeffective heart with a reduced intrapleural pressure, so now the heart is actually functioning less effectively, but we have a more negative intrapleural pressure. So you can see here at these relatively low levels of right atrial pressure, cardiac output actually appears to be doing the heart seems to be doing better off because you have a higher cardiac output at any given level of right atrial pressure. But pretty rapidly, you reach a point where further increases in right atrial pressure no longer increase cardiac output any further, despite the fact that we have a wider transmural pressure gradient. And so again, this would be the combination of a hypoeffective heart plus a reduced intrapleural pressure. Okay. Again, 2 interventions that are relatively complicated, but you just need to break these things down one by one. So again, walking through this very quickly, we've got right atrial pressure as the independent variable, so what we're changing at a given pleural pressure. So you increase pleural pressure, that's going to reduce right atrial transmural pressure, decrease preload, but that hyper-effective state of the heart is going to allow you to have a higher maximum cardiac output once optimum preload is reached. Again, flip side of this being the hypoeffective heart with more negative pleural pressure, that decrease in pleural pressure is going to increase the right atrial transmural pressure gradient, increase preload at the relatively lower pressures, but that hypoeffective heart is going to result in a lower maximum cardiac output once you reach a state where preload is optimized. And so again, here you're going to have that left shift only visible at the low right atrial pressures, and then ultimately you're going to be right shifted at higher right atrial pressures. So hopefully that makes some sense, and that you can start to think of different physiological states in which transmural pressure gradients across the ventricle are going to be altered in the net effect on cardiac output and right atrial filling pressure. And so now that you appreciate this, at least initially, we start to think about, well, what are the relationships between right atrial pressure and venous return? Because right now, so far, we've really thought about this in the context of right atrial pressure, change in cardiac output. Now, what about right atrial pressure and venous return? And so when we're looking at this reciprocal sort of relationship of right atrial pressure progressively being increased now as an independent variable with venous return, now you're going to see that you can start off with a relatively negative right atrial pressure, and then you have this plateau phase out here. But then as you increase right atrial pressure, you hit a transitional zone, and then you end up having progressive downslopes in venous return, which ultimately can reach to zero theoretically. And again, if you're looking at where you're sitting physiologically, you're normally starting here around zero. A little bit more negative right atrial pressure is going to pull venous return, widen that pressure gradient, and augment venous return significantly. But ultimately, the reach your plateau phase, increasing right atrial pressure is going to result in that downslope. And that point at which right atrial pressure ultimately results in probably the transient, physiologically, the transient sensation of venous return. That is defined as the mean systemic filling pressure. So again, if we're looking at this, sort of breaking this down, we get an increase in absolute right atrial pressure. That's going to decrease that pressure gradient sort of from pump to pump from the periphery, decrease venous return. When we decrease absolute right atrial pressure, we're going to increase the pressure gradient from the periphery, increase venous return. We'll have a central blood volume shift, and that's going to ultimately reduce venous volume, and that reduction in venous volume is ultimately going to have a limitation in terms of how much blood flow you can translocate centrally. So when we start to look at stressors to this response and changes in response to alterations in right atrial pressure, you can see here that with a change in venous tone, which is most often the change that people are interested in, you can see here we've got a change in mean circulatory filling pressure at any given vascular volume. So here we get an increased venous tone. And what that's going to do is at any given blood volume, that's going to increase the mean circulatory filling pressure. Okay, and so that's probably one of the more important components here, because you're not going to be changing your functional overall volume very much with any of these interventions without blood transfusion or blood loss. And so here, we've got our sort of normal relationship between right atrial pressure and venous return. Over on the right side, we've got our change in volume, and then we've got mean circulatory filling pressure here on the y-axis. And so you can see that as we look at, let's say, a normal circulatory system, you can see as we increase volume of that circulatory of the venous circulation, we will get increases in mean circulatory filling pressure. And of course, those are consistent with changes with the capacitance sort of storage of the function of the venous system, and you will have some pressure that's stored there, of course, but this is relatively, in the grand scheme of things, relatively low. But you can see this is just sort of normal operating volume. If you reduce the volume a little bit, you're going to reduce mean circulatory filling pressure. If you increase the volume a bit, you're going to have an increase in mean circulatory filling pressure. Now, critically, if you take something like strong sympathetic stimulation, where that fight or flight system is brought into play, and you're trying to mobilize blood volume centrally, you can see here that at any given vascular volume with very strong sympathetic stimulation, you can have a tremendous increase in mean circulatory filling pressure. And here, you're looking at roughly an increase from about 7 to over 14, which is roughly a doubling of your upstream driving pressure for venous return. And again, thinking of this in the context of your normal right atrial pressure is around 0. So this is a very large increase in the driving pressure for venous return. The opposite of that being complete sympathetic inhibition. So there are drugs that you can use to do this, to inhibit the sympathetic nervous system, like hexamethonium bromide. And there you can see again that under normal conditions, you're hanging out here. And if you get something that completely inhibits your sympathetic nervous system, you can have a pretty substantial drop in mean circulatory filling pressure. And so for individuals actually with significant autonomic dysfunction or dysfunction of that sympathetic nervous system, it can be a huge problem for them, even just to transition from lying down to standing up, because then you're going to have significant pooling of blood in the venous system, because you're not going to have that appropriate level of tone that's going to promote venous return and maintain mean circulatory filling pressure and subsequently maintain right atrial pressure and cardiac output. And so it's a huge problem for those individuals. And so, again, this is just generally showing you these relationships between sympathetic stimulation, sympathetic inhibition. You want to think about this as being really at almost any given operating volume and the subsequent impact on mean circulatory filling pressure. So again, when we start to place this now in the context of our right atrial pressure and venous return curves, you can see here's our normal curve. Again, just as the example that we had there, with strong sympathetic stimulation, we've got a mean systemic filling pressure or mean circulatory filling pressure, so those are used often interchangeably here, being roughly 14 millimeters of mercury. And so now at any given level of right atrial pressure, you can see that you can actually have very substantial increases in venous return, subsequently very substantial increases in cardiac output, because those must be equal in the steady state, that are mobilized due to venoconstriction and central mobilization of blood volume increases in preload. And so you can see that can be quite profound with sympathoexcitation or sympathetic stimulation. Similarly, you can have roughly a 30% reduction in cardiac output with a loss of sympathetic outflow. And so that can be a substantial hemodynamic challenge to an individual, even when just doing very simple activities of daily living. So hopefully this makes sense in terms of translating those two studies, those two figures between one another. So again, when we start to break this down really quickly, an increase in mean circulatory filling pressure, again, that's in our hands roughly approximate or similar to increases in systemic filling pressure. So at any given pressure gradient for venous return, in an absolute right atrial pressure, we're going to have a still higher pressure for the gradient for venous return. And that increase in venous stress volume is going to result in an increased stress volume, a decreased compliance at any given volume, reduced collapsibility, and a higher plateau, as you can see here, for venous return at any given right atrial pressure. Now, when we look at sympathetic inhibition, it is largely the opposite, where we've got lower stress volume, lower venous return, a lower plateau, greater risk of greater propensity for collapsibility, and a lower plateau here as well. So tremendous problems and challenges to the circulation. Now, when we look at intervention, sort of number 3, if you will, on the venous side, this is the concept of changing resistance to venous return. Now, I think the important thing is that this is actually the resistance to outflow from the venous circulation, not necessarily a change in resistance to blood flow overall because of venous constriction. That is not what these figures generally are representing. They are representing a change in resistance, let's say immediately proximal to entry into the right atrium. And so there, a relatively small increase in resistance can result in substantial backflow or damming of blood back in these relatively high compliance vessels, and that's why these become so steeply altered by changes in resistance. But you can see here that here's your normal sort of relationship with a normal amount of resistance. If you increase resistance to outflow from the venous system, what you're going to have is a very rapid damming of blood back into the circulation. and a substantial drop in cardiac output. Similarly, if you're able to reduce resistance significantly, whether that is simply through the translocation of blood centrally or through the amelioration of some sort of obstruction to resistance to venous return on the venous side, you can have actually very dramatic increases in venous return at any given right atrial pressure. So again, this is resistance to outflow from that system, and you can think of it as changing the damming of blood back up in a relatively high compliance system. So again, to make it a bit more explicit, it's a pressure drop somewhere in the venous system due to a change in resistance, not venous tone per se. So at any given absolute right atrial pressure, you'll have a lower pressure gradient for venous return due to that pressure drop. And that's going to result in a decreased stress volume and increased compliance, increased collapsibility, and a lower plateau as well. So all those things very consistent here. So if we start to combine these things to say, well, how can we optimize venous return in times of stress, or what are the things that are tremendous insults to the system that ultimately result in disabling cardiovascular function? You can see we've got our normal conditions here, so if we take normal conditions and increase venous resistance or increase resistance to outflow from that venous system, you have to have a very dramatic increase in systemic filling pressure in order to actually push blood flow back up to somewhere where you'd like to be, and oftentimes that is just not sufficient here with a relatively high increase in resistance. However, if you end up reducing resistance as well as concomitantly increasing mean systemic filling pressure, that's kind of the best of both worlds. And there you end up augmenting your upstream driving pressure at this mean circulatory filling pressure, that mean systemic filling pressure, reducing resistance. So you have a very steep curve here and a very high, very negligible plateau. And that is where you can really optimize cardiac output and venous return at relatively low operating right atrial pressures. And you can just see here that sort of with a 1/3 resistance, you have to have a very substantial drop in mean systemic filling pressure, and even there, you can end up exceeding your normal cardiac output and normal venous return with very low systemic filling pressures. So as we sort of stated at the outset here, cardiac output has to equal venous return in steady state. So that's just a must-have. And so if you think about just how you have to draw these curves, the simplest thing to do is just start off with a good old chi-square sign or whatnot, or just draw an X, and that's not a bad place to start. But if the intersection of the X is roughly at 5 liters per minute, that's not a bad place to be under normal situations. And you can see here that although you might have a very transient change, let's say in right atrial pressure, and you might increase right atrial pressure, and push cardiac output up transiently, in the absence of a change in the properties of the venous system, that's going to pull you back to this 5 liters per minute here. And so it's not until you have a change in the mechanical properties of one of these systems, for example, depicted here, where you have an increase in mean systemic filling pressure and a reduction in resistance to venous return, that you can have actually a very dramatic increase in cardiac output with no change in the, quote, effectiveness or state of contractility of the left ventricle. So this, again, highlighting that interplay between the mechanical properties of the venous system and how they influence central cardiac function. And so again, here just with A and B, A is at the systemic filling pressure of 7 millimeters of mercury. B is at systemic filling pressure of 16 millimeters of mercury. That's going to augment that driving pressure for venous return and increase right atrial pressure at any given resistance to venous return. So hopefully, as we look at some of these curves and how they have implications for responses to physiologic stresses, they're not as confusing as they might be at the outset. And the many instances where this can actually have profound implications clinically. So here you got your normal state, and with spinal anesthesia, or in cases of substantial fight or flight, you can start to piece together what the implications of these interventions or insults are on steady state cardiac output and venous return, and ultimately understand how you might need to intervene to offset some of those changes and ultimately maintain cardiovascular homeostasis even as a relatively short term. So with that, thank you very much, and I'll look forward to seeing you in the next lecture.